Ibrutinib is now FDA approved for treatment of CLL patients, regardless of the patient's prior treatment history or cytogenetic status. So it is the leading kinase inhibitor with the broadest clinical indication at the moment. However, there are limitations with single-agent ibrutinib, one being the lack of deep response. We treated more than 84 patients on a phase 2 clinical trial using single-agent ibrutinib and did flow cytometry to measure the minimal residual disease at annual time points on study. And even with 2 years of continued therapy, no one reached minimal residual disease negativity. And in fact, majority of the patients had a lot of disease circulating and detectable in blood. So deep response is not so feasible with one agent. The second limitation is drug resistance. And you may have heard that people would develop mutations, typically in the BTK gene and PLC-gamma2 gene, which alters the drug binding or activates the downstream B-cell receptor pathway and making the drug ineffective. And when these mutations develop, it happens early on during the treatment course. We applied targeted sequencing to the patient samples who progressed on ibrutinib and learned that drug-resistant mutation happens 15 months or even many years before clinical progression occurs. So these data get together and tells us that it is insufficient to target just the B cells in order to overcome clonal evolution and prevent these from happening. We have to reach beyond leukemic cells and recruit non-leukemic cells. So in these contexts, we designed a new study using single-agent ibrutinib and adding a short-course fludarabine on top. What ibrutinib does is it targets B cells specifically. Fludarabine is a well-established lymphodepleting agent. It can debulk both B cells and T cells. So we would like to combine two drugs together and achieve deeper response. So we launched an investigator-initiated phase 2 study using these drugs. People get ibrutinib from day 1, continue it throughout, and fludarabine is given over 2 cycles on cycle 3 and 4 only. And this study has a 2-stage design. 13 patients would be enrolled to stage 1, and if we have more than one complete response, we consider the stage 1 to be successful and move on to enroll 14 additional patients for stage 2. So far, we have accrued 13 patients to stage 1 and reported the interim result in the iwCLL meeting. 13 patients were previously untreated. Half of them had advanced rise stage unmutated immunoglobulin gene, and 23% had high-risk markers such as deletion 17p. And the outcome was we saw deeper response and earlier reduction of CLL cell burden even after just 6 cycles of therapy. The overall response rate after 6 cycles was 100%, so virtually all patients who were treated on this study responded. 3 out of 12 evaluable patients, which was equivalent to 25%, achieved complete response. And although there is a caveat of cross-trial comparison, our CR rate appeared to be higher than what had been reported with the single-agent ibrutinib. For instance, RESONATE-2 study, which used single-agent ibrutinib in elderly population as an upfront treatment, CR rate was only about 4%, and their median follow-up was 18 months. So in comparison to that, our CR rate appeared to be much more exciting. Then we looked at each compartments affected by CLL, such as lymph node, spleen, blood, and bone marrow, to see if we had an even reduction of CLL cell in the body. And we did see marked reduction in all of these compartments in all of our patients. So those are the results that we have. As for the safety, we did observe a drop of neutrophil count and platelet counts, especially during the time when fludarabine was given. Grade 3 to 4 neutropenia occurred in 7 patients. Grade 3 thrombocytopenia occurred in 2 patients. However, this drop of counts occurred during the time when fludarabine was added. And when it was completed, they all bounced back to their baseline. So these side effects were manageable. So taken together, we're very excited about the trial result. The study is open for the accrual of the second stage. Moving forward, I see this Ibrutinib and short-course Fludarabine as an excellent platform to add on immunotherapy. This trial was building upon the idea that we can reach beyond T cells, and we would like to actively recruit T cells to target CLL cells and achieve deeper response. So right now, we're planning on a new trial using this Ibrutinib and short-course Fludarabine as a platform and adding an immune checkpoint inhibitor called pembrolizumab. And we anticipate to open this trial early this summer.